كيف الجراحة باستخدام الروبوت طورت جراحة الأورام. اليوم كان افتتاح المؤتمر 27 الدولي لجمعية الأورام الأردنية برعاية وزير الصحة الدكتور إبراهيم البدور. Assalamu alaikum. Good afternoon, and thank you everyone for the invitation. My colleagues, my friends, Dr. Isa, Dr. Tahir, and everyone else. My name is Tarek Al-Hammouri. I'm a robotic urology and neuro-oncology consultant at University College London Hospitals and also at the Specialty Hospital Namman, and also the co-chair of the North Central London Uro-Oncology MDT and the researcher at UCL. I'd like to start with a simple question. In oncology surgery today, what defines a good operation? What are we really trying to achieve? Is it removing the cancer? Is it minimizing complications? Or is it how well the patients do after we operate? And I think because over the past decade, much of that has changed, and it changed dramatically, and much of that came from robotic surgery. But to understand where we are, we need to see where we started. This is how surgery started. No imaging, no precision, and at times not even reliable anesthetic. Speed was the surgeon's greatest skill, because the faster you operate, the more likely the patients will survive. It was bold, it was life-saving, but it was also brutal. And for a long time, this is the surgical Ibn Sina armaments. One second. الماوس اتحكم فيه من عندي. أيوه. Thank you. And for a long time, even in modern oncology surgery, the philosophy didn't change that much. This is where most of us trained in open surgery. In open surgery, it was large incisions, direct access, and reliable cancer control. Then came laparoscopy, smaller incisions, less pain, and faster recovery. But then we started comparing success with that in the middle. How big is the scar? How small is the scar? The smaller scars or smaller wounds don't always mean better surgery, because what really happens is what happens inside the surgery. Now, this is what changed everything: robotic surgery. Now, for the first time, we're not operating at the anatomy, we are operating within the anatomy. And this really changed everything about how we think about surgeries and tumor surgery. We can see layers, we can see planes, structures that were never this clear before. And that changed the goal of surgery. It's no longer just removing the cancer, it is trying to remove it precisely while preserving the tissues around it to improve the patient's quality of life after surgery. So here we measure outcomes not with smaller incisions, but with patients' outcomes, oncology control, and also quality of life, and in the end, better surgery. So this level of precision is not just technical, it directly translates into what matters most to patients. As I said, for example, in prostate cancer surgery, patients care about the most is potency, continence, and quicker recovery. In the past, with open radical prostatectomy, patients used to bleed a lot, receive a lot of blood products, and longer stay in hospitals, longer stay off work, But now with robotic surgery, it's almost a day case procedure or one night stay in hospital. They can return to work almost immediately. At the same time, we are equally focused on the oncology control. And for example, here there's an image of the microscopic prostate capsule and how it looks like, and that shows you what precision surgery really means. So a negative margin is no longer enough. We are trying to get a negative margin, but removing the exact thing that we need to remove. So the question is, does this really translate into real outcomes? So this is the IROC trial. I was privileged to be part of the team. This is a randomized controlled study comparing robotic and open surgery in one of the most complex cancer surgeries, as you all know, radical cystectomy. Oncological outcomes are better, or at least equivalent. Complications less, and recovery faster. At least this randomized trial, one of very few randomized studies in robotic surgery proved this. So this is no longer experimental. This is no longer an idea. This is level 1 evidence-based surgery. Even in the most complex procedures, robotic surgery showed its value, and in many aspects, it is better. Now, this is where things really get interesting. Traditionally, in cancer surgery, we used to make a compromise. We either remove more tissue to be safe and get a negative margin, or we preserve the tissue and function, but risk leaving disease behind. That balance we have always accepted, but now with this, for example, this new approach, the NeuroSafe, this is assessing margins in real time, as in frozen section during surgery. So we are no longer guessing, we are deciding with information, which means we can do more nerve-sparing surgery in a safe manner without compromising cancer control. So now we have moved on from better tools to better surgery, and again, with level 1 evidence. So how do we actually deliver this level of precision consistently? And this is a very tricky point. So it's not just about the robot, it's about standardizing the operation. And this is the basis of the cup technique that we developed. It's a structured way to make complex surgery predictable. So even in complex surgery, we created this video, a stepwise manner to perform the exact operation every time. And that's what we mean by consistent and predictable. So it's a stepwise approach, clear anatomical planes, and reproducible techniques. So outcomes are not dependent on individual brilliance. It is on a system that can be replicated. And that's how you scale quality. Decisions drive outcomes, not just the operation. So robotic surgery, obviously, and technology is not enough. This is a multidisciplinary approach. In our work on streamlining MDT, we demonstrated that structured MDT and prioritization improves efficiency and decision-making in complex cancer cases. And of course, we need the full team with a pathologist, radio oncologist, medical oncologist, radiologist, and the rest of the team, all together for better patient selection, imaging and planning, surgical execution when needed, and the oncological strategy. One of the major advantages of robotic surgery is not just how we operate, it's also how we train and how we scale these expertise. How can we make more surgeons do the best surgery, or at least the standardized surgery? So, for example, with robotic surgery, surgeons have better view, trainees have a better view. Surgeons, the seniors can take control of the surgery when needed, and they can also be very close to when their trainees are operating. So they are more comfortable giving away some steps of the surgery. And then Teleproctoring. Teleproctoring is another idea that was developed with robotic surgery. The mentor or the proctor can actually follow the surgery with their trainee or the less experienced surgeon online, speak to them in real time, give them advice, give them directions on how to do things better. And then we are now moving towards telesurgery. So this is a picture of my friend and colleague, Dr. Yunus Halal. He is a Moroccan urologist and robotic surgeon. He did the first telesurgery. So he was in China, operated on his patient in Morocco live. So he told me a lot about this. He told me about the experience. I've met a few other surgeons who did that. And in this way, expertise are no longer limited by geography. This means we can build high quality programs faster without compromising standards. What the future holds for us, it's not just better surgery, we're talking about smarter surgery. For example, AI assisted planning that can help us choose the right approach for the right patient. Image guided surgery, where we can integrate MRI and real time imaging into the operation and show us the anatomy right there inside the patient. Personalized surgery, and also what Dr. Tahir just touched upon and talked about is the liquid biopsy. We had some work on liquid biopsies looking for circulating tumor cells in advanced prostate cancer cases. And this is the protocol of the study if anyone's interested to scan the QR code. So that way, the surgery is just no longer technical, it becomes data-driven. My hope is for you to take home some of these messages, that robotic surgery is a means, it's not the end point. Expanding indications must never compromise outcomes. Standardization and MDT is exactly what makes this safe and scalable. And the future is the combination of data, precision, and judgment. Robotic surgery is not about the technology alone, it's about raising the standard of care. And that standard should not depend on geography. Our patients here in Jordan deserve the same precision, safety, and outcomes. Thank you for listening.